University of Washington talking to us about their experiences and lessons learned with working with Project Echo. Let me take just a second to go around the board here and show you some of the features we have. First of all, you can see our presenter in the top right side of the screen. Then down below that, you'll see a number of files that you can download. One is a flyer for our conference that's coming up in Seattle in March, and we certainly invite you all to come and join us there. We've got a lot of great opportunities for networking and education. In the web links module just below that, you'll see that there's a link to our website and to our SurveyMonkey survey on your impressions and thoughts about today's webinar. And more importantly to me anyway, is what kind of webinars you'd like to see in the future. We really would like to respond to what you want to see. So if you tell us, we'll try to get it for you. In the lower right corner, you'll see the chat module. That module is to help you resolve technical issues. If you've got questions for me or for Martha, who's monitoring this, we can try to help solve technical problems. In the Q&A pod to the left of that is a good place for you to ask questions of Marlene as she goes through her presentations. Marlene's an old hand at using Adobe Connect, and she'll keep an eye on that Q&A pod, and we'll answer questions at the appropriate time. So, without further ado, just one last thing on the survey. We find that people are kind of hesitant to do that, so Martha has found a clever way of getting the survey on your screen. We'll just put it that way. I'd like to introduce today's speaker. She's trainer, author, and researcher Marlene Maheu, PhD. Marlene is the executive director of Telemental Health Institute, Inc., where she's overseen the delivery of professional training in telemental health to more than 2,500 professionals in 39 countries since 2010. For more than 20 years, she must have started when she was in grade school, Marlene has focused on the legal and ethical development and use of technologies to better serve behavioral health clients and patients. She served on a dozen professional association committees and task forces related to telehealth. She consults and lectures internationally on the subject of best practices and risk management in the use of various technologies and has written dozens of peer-reviewed articles. She was lead author of 2 telehealth textbooks and is currently writing 2 more. She's a staunch advocate for using technology to reach more people, reduce healthcare costs, and improve the quality of care via self-help, wireless technologies, robotics, telemental health, and telesupervision. She's known for her innovative yet easy to implement strategies for getting started immediately, and we are happy to welcome Marlene, I'm sorry, I did that again, and invite you to have a good time with Marlene.
Thank you, Bob. It's always a pleasure to work with you. So please feel free to ask questions, and I'll try to spot them as they come through and try to build it into what I'm saying. So don't wait to the end if you really have something you want to know. Let me just tell you a little bit about me. I am a psychologist. I'm not an attorney. I'm not a physician. I'm not a marketing or information technology professional. I come at the work that I do from the perspective of a clinician, and that's where I started, and I wanted to figure out how to do this right, so I focused on legal ethical issues, and that's what took me to this 20-year path. But my goal is educational. I'm not here to tell you that what all the rules are, the laws are, but I can give you my sense of what is appropriate and point you to the right people. So I want to alert you to what's happening in a way that will help you think through the issues that you deal with, help you manage your risk and that of your clients and your patients when they come on board to work with you. I don't offer you a warranty, guarantee, or representation as to the accuracy or the sufficiency of the information contained in my presentation for your specific circumstance. This is a rapidly evolving area, and I encourage you to try to stay current. We do have a free newsletter at the Institute. You can go to telehealth.org, and you'll see in the top toolbar it says newsletter. You can sign up there. We have regular webinars, so you can stay on top of this information for mental health in particular. Our focus is mental health. Behavioral and mental health, but that's it. So we're very specialized in that. So with all the information, though, we don't assume responsibility in connection with your choices. So we encourage you to think carefully about what you're doing. Your part, of course, is to get yourself trained and to be competent in what you're doing. There's a lot of guesswork going on out there. I just saw this week a full article on how physicians are getting in trouble because they are not doing a full informed consent, and all the different little areas are coming out about what really needs to happen there as a reminder to people since they may have forgotten since they went to medical school or graduate school. So in any case, whatever you have to do to be competent, then I'd also encourage you to get written approval from your legal, regulatory, ethical, and malpractice bodies, because until you have that pinpointed down in writing, you may not be very clear and may not want to start offering yourself as a professional delivering services. And then I strongly want to encourage you to have an informed, trusted, local, clinical, and legal consultants take a look at whatever written responses you get from these authorities, because sometimes there are hidden nuances that you may overlook and make some decisions that are not fully informed because you haven't really registered what the words are that you're getting. So really want to encourage you to lean in the direction of some consultants to try to get accurate information before you implement anything. So I'm going to give you some broad stroke observations, and we're going to pack a lot of information. I do 2-day workshops on this topic, so it's all crammed into about 45, 50 minutes. So uh, put your seatbelt on, and please, if you're looking at email and your phone is on, I strongly want to encourage you to turn it off so that you really get a lot of these points, because a lot of people miss things and come back and ask me questions about things I already talked about. But part of that is because I speak rather quickly, so a little warning there. And then, in any case, we're retooling so that it's not just the healthcare world, it's not just the United States, it's the entire planet. And I think it's important to get that perspective because we're caught in a whirlwind and sometimes we don't realize what's happening, but there's a lot more going on than many of us are able to see. So I'm going to be talking about some learning objectives here. We'll talk about some legal ethical practice over state lines, how to make sure that happens without a problem on your end. And then I'm going to give you at least 2 reasons why Skype's been identified by some of the leading groups in the mental health organizations as being inappropriate for what we do. And I'm going to give you some places to get some alternatives to Skype. I'll talk to you about the informed consent. I'll talk to you about multicultural issues of relevance, talk to you about managing risk associated with mandated reporting, suicide, homicide, and give you some models. At the end, hopefully we'll have time and we'll go through at least 5. I actually think I have 10 models for success on how to practice online. Back in the year 2000, I published a model that was called the Online Clinical Practice Management Model, produced a textbook that went through great detail about that model. And what we tried to do in that particular textbook was to boil down all of the training, the referral systems, patient education information, the legalities, assessment, direct care, reimbursement, and put all that in one place for you so that you wouldn't have to go look at a lot of the code sections and the other things that people really don't want to be looking at. So hopefully this is going to give you an orientation to that, but just so you know, there's a lot out there. Now, what I'm focusing on primarily is video, and I want to just point you in that I'm not going to be talking about email and a bunch of other things, text messaging, although we have plenty of training on that at the Institute, but today we're just going to focus on video. And when we look at what consumers want, there's a lot of information to show that consumers really want video. This was a study that was published as a result of a Mayo Clinic survey in the spring, in September of 2014, so just a few months ago, about how many people want information over video-based appointments to their homes. And you can see a lot of people, 75% in this particular study, said they wanted that. So our systems are moving in that direction, and that's legislative systems, regulatory systems, reimbursement systems, and of course our technology systems. The last on the list, though, is the clinical. The clinical world is pretty much the slowest to the table here, and That's why I'm hoping that some of you in the House today are clinical folks and that you can be some front runners for some of your colleagues. But part of what the government's doing is they are helping this adoption rate along by saying, okay, if you misdiagnose somebody or mistreat somebody during an emergency room or hospital readmission, um, we're going to pick that up because we won't pay for readmissions in 30 days. And what they found when they did that, this is a study, this is a slide I got from a presenter at the American Telemedicine Association meeting just in September. What they found was that from 20 to 10% of the people who were not getting paid because of readmissions within 30 days to hospitals were had mood disorders. What that means is that of all of these rather serious disorders that were the cause of readmissions, that mood disorders for Medicare were about 20% of the folks, 1 out of 5, were getting readmitted because of a mood disorder or had a mood disorder when they were readmitted. And then Medicaid was 17%, commercial was about 10%. So from 20 to 10% of the people getting readmitted related to mood disorders, well, that's our territory. So that's why we're seeing a lot more interest these days in behavioral health care, because the hospital administrators, the healthcare administrators are recognizing across the board that behavioral and mental health disorders are pretty high on the list of what's costing money in this country. And I separate out behavioral and mental health because those really are two different areas. If you look at exercise, all these Fitbit and Basis Watch, all these devices that are coming out trying to engage people and to get them to adhere to exercise regimens and proper food regimens, what they're seeing is this involves behavior. So that is behavior management, and it's quite different from mental health problems because a lot of people may have a mental health diagnosis, but a lot more people have behavioral problems. And all of that is the purview of the licensed clinician in our country, in the United States, and also in some other countries, Canada and a lot of other westernized countries. So our world is very big, and they've not been using us to our full capacity. So we can expect a lot more work in the years to come. And that's all part of healthcare reform and where they're going because they definitely want to increase access, decrease costs, and hopefully improve care in the process of all of this. So that's why telemental health is such a big pivot point. And when I spoke with John Linkus, I actually interviewed him for some of our training last year at the Institute. He identified for us that telemental health was one at that point in time of the top 3 growth areas for telehealth. And I believe that that is inching up the ladder as time goes on. I'm hearing from some attorneys at CTEL, the Center for Telehealth and eHealth Law, that telemental health is the next big wave. So finally, after 20 years of work for some of us in the trenches here, we're starting to see that there's much more recognition that if you catch somebody early in the trajectory of their problem, so let's say you catch a 5-year-old here with some behavior problems, that perhaps they won't escalate to be somebody who needs to be incarcerated at a later point in life, perhaps for years on. For years. So it's good to catch people early with behavioral and mental health disorders. So that prevention that many of us were talking about years ago is finally getting some recognition in Washington. Now, people may say, well, what's the size of the evidence base? What's really to show that it is that telemental health is strong? There are over 3,500 that we at our 3,500 references that we in our institute have organized, and that is primary source references. I'm not talking about a popular magazine or a website, little reference, just kind of summarizing somebody's survey. I'm talking about peer-reviewed journal articles and books. So there are a lot of studies that show the efficacy and the ins and outs of that. And we have a free list of 1,000 of those that are searchable at our website, which is telehealth.org, and you can find that for bibliography. So you can go there and just type in teenagers or adolescents or ADHD or depression. You'll see a slew of things pop up for you. So you can go there and just do a little bit of a lit review yourself. I'm going to point out 2 studies for you. There's another third one. I didn't want to take up too much time, but anyway, Linda Galetsky and her colleagues reported in April of 2012 a 25% decrease in hospital utilization in a sample, and I want to point this out to you, a sample of 98,609 subjects. Now, I don't know about you, but I've been doing this for a while, and I've never seen a sample of 98,000 anything. So 98,609 telehealth subjects. This is noteworthy study. Encourage you to go take a look at that. I give you the references to my studies here. Also, Buckhouse, that same spring, May 2012, reported a meta-analysis of 821 potential articles, boiled it down to 65 that they selected, and they said that results indicate that video conferencing is feasible. Video conferencing psychotherapy is feasible. It's been used in a wide variety of therapeutic formats and with diverse populations, and is generally associated with good user satisfaction. So the patients are happy with it, as well as the practitioners, and it's found to have similar clinical outcomes to traditional face-to-face psychotherapy. Now, these are in highly controlled environments. It's not the same on the internet, but these are in traditional telehealth models. Also, Hilty and his colleagues, Don Hilty and his colleagues, just produced another study with very similar outcomes. So there's a lot coming out. His study was in 2014. But I want to point out that when you look at those studies, they generally are studies of people that are referred to traditional telehealth models, oftentimes run through a university. So that would be the physician's offices, the mental health practices that refer patients to one of those hospitals. And the hospitals then have a referral source that serves as an emergency contact, serves as a backup system. If somebody needs to be removed from a study, they go back to the physician's office, and there's an entire community set up to handle any emergency. It's very different from what many of us have come to see as advanced online as online therapy or online psychotherapy. So I want to differentiate the two models for you because this is pivotal when you're looking at best practices. When you go online for therapy, usually that's email and chat. Many of those people now are starting to use systems like Skype, and we'll talk about Skype in a moment. But when you're looking at a traditional system, it has been video pretty much from the get-go. First study in Telemental Health was 1959. They used video for that, and so we've been using video ever since. Online, a lot of these worlds are anonymous. You might have heard in the news that Big White Wall made a big splash just last week at the mHealth Summit. Big White Wall is an anonymous service. We'll talk about that later when we talk about, well, how do you do mandated reporting? We're mandated reporters or licensed professionals. How do we deliver care in an anonymous environment? Those are some of the issues that come under best practices. When you work in a traditional telemental health setting, like I said, let's say it's a university with patients referred from local hospitals or local physicians' offices or clinicians' offices, those patients have been identified and their credentials verified by an admin. There's a driver's license that you have to produce. There's, people see you so they can talk to you. So they watch you fill out that form. Are you filling it out yourself? Do you have somebody else fill it out for you? There's a lot that can happen in that verification process that does not happen in an anonymous situation online. Online, you get self-referrals online largely. In traditional telehealth, it's largely referrals from a clinical source. Online, they'll often disclaim any responsibility. They'll say things like, if you're suicidal or homicidal, then we can't work with you. That's not typically how it works. When you have a traditional telehealth model, there is a referral network, and everybody knows the local emergency room is and or other services, different crisis services that can go out to the home and help with a patient who may not be responding. Maybe do a safety check with a police officer or something like that. Also, online therapy, no clear channels for mandated reporting. Online, everybody who's working in a traditional model does do mandated reporting. And a lot of times online, because it's anonymous, there are no patient records. How do you identify people, right? They're anonymous. So when we practice in a licensed traditional model, everybody is required to document the contact with that patient or that client online. So you see there's some drastic differences there. When we work as a licensed professional, then we need to follow all of the existing legal and ethical rules. Some people think that because it's online, the rules are different. I just did a webinar for my institute yesterday on text messaging, and I did some polling of different clinicians to see what their practices were when I prepped for this webinar yesterday, and got a question I think is very typical. So I'll just give you an example. One psychologist said, if we are receiving text messages from patients, I understand that it has to be HIPAA compliant. But if they are texting to us, do they have to be HIPAA compliant? You see the confusion about HIPAA. First off, we're clinicians. We have to be HIPAA compliant no matter what device we use when we're talking to anybody. The patient does not have to be HIPAA compliant. They don't ever have to follow any type of secrecy or privacy rules because they hold the privacy, right? They hold the right to that privacy. Our job is, as clinicians, to protect their privacy, and that's called our legal duty to hold their material confidential. You see? So people are confused about that. Also, HIPAA is something that applies both ways to devices. So in her question, if she's the person that is sending the message, she has to be HIPAA compliant. In her sending of that message through a device that meets the standards of HIPAA, but also she has to be compliant when she's receiving the message, even though the patient's sending it, she's the one that needs to be compliant. So people get confused with these rules. It's important, though, that everybody understand that whether you understand it or not, you have to be compliant. You see, this is sort of an issue of ignorance is not a defense in the face of the law. You need to be compliant because these are the rules they need to be operating under. And HIPAA is a federal law, so there's really no getting squishy about that one. Have to be compliant. Now, the associations have issued guidelines. Associations and legal, and people get confused about associations and legal issues as well. Legal issues are matters of your licensing board and you, if you're a clinician, okay, or federal laws, privacy laws, confidentiality laws. Those are legal issues, right? Professional associations are groups of typically practitioners or researchers that get together and try to lobby legal groups to change laws or to enact different laws that are beneficial to that professional group. So what we've seen in our country, the United States, is that our professional groups, American Counseling Association, Psychological Association, Telemedicine Association, Association of Social Workers, have all issued guidelines now for telepractice. And I give you the names of those documents and the dates here. So if you're in one of those groups, you can go and look at those documents. I haven't seen anything published by the American Psychiatric Association, although I believe they follow what the American Medical Association has said. And the American Medical Association has been rather specific about a number of these types of standards and guidelines for telepractice. If you're in doubt about the fact that these things exist, we have a list. Also, you can access this for free at our site, telehealth.org, ethical statements. And so this covers standards, guidelines, and also some research, some interesting research articles there that are coming out. But you'll see it's an international list. Australian Psychological Society has actually a very, very good list because Australia is about 10 years ahead of us with their telehealth build out. So they, because of the outback, the interior of the country, they've had to traverse a lot of territory, and they have been at it for much longer than us because they have a single payer system. The Australian government says, we're going to do this, gang, and everybody does it. So they don't have 50 states kind of arguing with each other about all these rules. They just kind of go ahead and do it. And we see the same thing with Britain. So there are a lot of Canadians. So these folks have been doing this for a while. If you're getting involved with this and you want to understand from the professional association side of the house what is important in their minds for those types of the different disciplines and the specialists they have, I encourage you to go to some of these other ones because they foreshadow what ours will be producing in the United States. So if you see something, for example, in the Australian Psychological Society guideline, you're likely to see it in the American Psychological Guideline sooner or later. It's coming down the pike. Not always, but definitely. And New Zealand is also pretty far advanced. So You can go there, and if you find any that we haven't listed, let us know, because we're always happy to update things. Let me talk a little bit about multicultural issues, because I'm pretty interested in this myself. I come from an immigrant family. My family's French Canadian, and um, our language was French, obviously. So when I moved to the United States, I did a lot of translating because I grew up in American schools, and I'm very sensitive to these multicultural issues. Early on, I recognized that a lot of the things that my little friends were talking about in school were quite different from what my cousins were doing in Canada, and I didn't understand why. And now I can appreciate, from my perspective as an adult, that there are very, very different ways of looking at the world. And when we when we take technology to enter into somebody else's world to try to help them, it's our job to be aware of those cultural differences and to reflect our ignorance when we don't really understand things. So it's not just a matter of culture, though. It can be a matter of a lot of different things. It could be um, straight therapists talking to homosexual couples. It could be people talking across racial boundaries, racial lines. It could be any number of things, as well as language, because if you think about some of the idioms that are used in the North, I come from the Northeast, I grew up in Connecticut, so the slang and the idioms are quite different when you move down south, or I live in California now. Even the California group, the not only is the accent a little bit different, but there's a different understanding of slang terms, and that's very important when we're talking with people that might be in some of these rural communities, that we at least get some training in what they may be talking about. So I'm doing a lot of development for competencies. So we're developing competencies. I'm writing about a lot of that these days in my books. I want to let you know that I'm finding a lot of research that talks about groups going into Alaskan tribes, for example, to deliver care and not understanding what these nuances are. And then it's relatively important to do that. It's very important to be aware of that. And when you're working online, there's some very easy tools for this. You can have somebody take a free English proficiency test, and there are a number of them. Just look up English proficiency test. Pick one. I like the one over at Microsoft, but pick any one of them. And after a while, you'll get to understand the norms. Give the test to a few of the people in your office, and you'll see that if someone has an 80% understanding rate, it may not be that great. They may not really understand that. You may use 80% in your head as a good demarcation of, it's good enough. May not be good enough. They may not understand what you're trying to say. And you may not fully understand them. And they have proficiency for auditory, so spoken word, as well as written word. Some people, I know in my family, many of my relatives can read English because they learned it in school, but the speaking of it is a whole other animal. And we as Americans tend to speak quickly, and they may not grasp what you're intending to communicate. So just be sensitive to this when you move into somebody else's territory. I'm going to talk to you about the American Psychological Association, the American Telemedicine Association, because they both produced guidelines in 2013 that we at the Institute took rather seriously, and we compared them. So I produced a document, and I'm happy to make this available to you if you'd like to just write to me. And you can write to me, maybe Martha, you can post this somewhere at telehealth.org/contact, and you can ask for this. I'd be happy to give it to you. I can also send it to you, Bob, and have you post it in your system if you'd like. But it's where we looked at the guidelines, and much to my surprise, because they're written quite differently, they overlapped on all but 4 or 5 items. And was I was surprised to see the differences. For example, the American Psychological Association says that you're responsible to understand forces that could impact your patient or client at the other end. Now, when I stopped and thought about that, I realized I can't be aware of all the forces that impact the person sitting in front of me if they don't tell me, but I'm responsible for that when I do telepsychology. So it's important to understand this and then cover yourself in your informed consent process when you do it. For example, the way to cover yourself on that one is to say, I'm not in your informed consent document, something like, and I'm paraphrasing, not an attorney, right? But paraphrasing, basically, I'm not responsible for what you don't tell me, right? So that you can say, hey, I went over this with the person. So it's the person's job to tell you what's impacting them rather than you trying to guess it or follow the news in their local area. So the another one that one distinguished the American Psychological Association, American Telemedicine Association said you need to document every communication you get from a client or a patient. If they text message you, if they send you something in email, if they send you something through a website form, you need to document that. Well, American Psychological Association didn't say that, but when you stop and think about good clinical practice, if you make a decision based on something that is not documented, you could be held liable for that when maybe it's just that they told you before that if such and such happened, they would try to kill themselves. Now that thing happened, you got that communication, so you're trying to reach them and you go above and beyond the normal course of action because you're thinking they're going to try to kill themselves. You see, so this documentation is important. Um, the thing to know that when you're practicing online, you have to document more than in person. It's just the way it is. So once people get over that, then they kind of can roll with it a little more easily. But uh, you just have to document more things. You have to be very careful about understanding your technology and the idea of, I'm going to go into some legal things now, but the idea of somebody operating an email without ever taking a course in how email can go wrong is just not a really good idea. Okay, so uh, be sure you get specific training on the types of technologies you choose to use. For example, if you use video technology, it's important that the audio channel works. And if you have to differentiate between which one is working, if you can have one or the other, sometimes that happens when you're doing video. It happened today when we were doing the setup for this particular webinar. Then choose the audio because on audio you can still maintain contact. If we only had video right now, what you would see if we didn't have audio, you see me moving my mouth, but you wouldn't hear me. Unless you read lips, you can't do the kind of work you have to do for clinical work. So you have to have the sound channel. So if the video breaks down, you have to disconnect and just go with a phone, for example. If the video is good, but you lose the audio on your video platform, you can call someone on the phone. Keep the video alive and call someone on the phone. Then you have the best of both worlds. You have the audio channel that's carried by your telephone and the video channel. So you see, you have to understand your technology and what really is useful for you in a clinical setting. So that's all I can say about that right now because of time limitations. One of the big issues here is interjurisdictional practice. And in one of the learning objectives for this course, I told you that I would give you information about how to practice over state lines. It's very easy. You simply have to get licensed in the remote state. Right now, that's the way it is. There are a lot of people working on changing this. There's a lot of pressure from above, a lot of complaints from clinicians that are in the trenches. But right now, you can practice over state lines. So when people tell you you can't, you can. Many states have rules that say you can practice in their state if you register with their board. And they'll tell you the number of days. 30 days, 60 days is common, although 30 days is much more common than 60 days. Some states don't want you practicing there at all, but you have to go read that state's law because there are different jurisdictions, right? So when someone hands you your licensure as a practitioner, they don't say, here's your license, now you can go practice in all 50 states. It's pretty understood. Here's a license, it's a California license for me, in my case, for example. And if you go use this license in Florida, you're not going to be able to use it in Florida. That's understood. But clinicians think that when you go online, it's a whole different world. It's not. You have to remain in your state. And I think in the last 2 or 3 years, people are starting to get this more and more. There was actually a case just this last week that was reported in Pennsylvania. There was an Israeli psychologist who advertised his service and used a Pennsylvania address. The Pennsylvania board went after him and found him guilty and disciplined him. And so now he's no longer announcing himself as having a Pennsylvania address. So the boards are starting to act on some of these rather blatant violations. Also, your own state could have a prohibition against you going into another state without proper approval. I call these rules the innies and the outies. You see, your state gives you a license to practice in your state. It could also have a rule against you going out of state without getting properly licensed. And you could be then penalized by your state for practicing in that foreign state as well as the foreign state. So that is true in California because it's a consumer protection state, you see. So not all states have that second rule, but many of them do. So be careful when you go into over state lines. Safest thing, just get licensed in both states. And some people think, oh, this is the end of the world. My question to people that think that is, why do you have to be practicing in all 50 states? Aren't there enough people in your state? If not, then perhaps you ought to focus on one state at a time and try to roll out your services so you have your referral networks built up. If you have multiple clinicians, that's a whole other discussion. And certainly I can help you with that. There are many groups that can help you with that, but it's certainly not prohibited. I will show you, though, if you go without a license to some states, what can happen. This was produced by the American Psychological Association. They've since updated it, but it's something called the Telehealth 50 State Review, and they went through and they cataloged all of the laws in the states related to telehealth. And what they found was that Utah and Vermont both had $5,000 penalties. If you look at the fine print here, oh, it's here. See, a little note shows up here. There's a possible fine of up to $5,000 and/or possible imprisonment of up to 5 years if you practice in Utah without a license as a psychologist. Same thing for Vermont. Possible fine of up to $5,000 and possible imprisonment of up to 1 year. So, there are state laws against going in those states. They haven't been enforced, but like I said about Pennsylvania, they're happening more and more. So, if you want to practice over state lines, here's how you do it. You go look at the professional code for that state or the country, if you want to go to another country. Don't be dissuaded by calling them and having people say, oh, no, we don't have any of that here. I just did this for someone. Some person she wanted to be licensed in a foreign state. She said, Marlene, I can't make any headway. Would you call? So through a consultation arrangement, I called for her, and the response I got from the person in that board was, oh, we don't have a telehealth law in this state. Okay, wasn't my question. I didn't say it this way, but basically in my mind, I said, okay, well, then if you don't have a telehealth law, that means if I'm licensed, I could practice in your state any way I choose, including video. Is that right? And she said, yeah, that's right. So you see, you just have to know what question to ask. So get the information you need to practice using a temporary license. Most states have this temporary license thing. So then you apply and you do whatever they say to do. Some of them make you take a test so you can get this temporary license. Take the test if you need to. Maintain your CEs or your CMEs if you need continuing education. And then inform your malpractice carrier and then be in touch with your regulatory associations. So your regulatory associations, your state board, be in touch with the state boards. See, it's not rocket science to do this stuff. It's just there are steps you have to do. Mandated reporting. You will want to be able to report somebody. If you're licensed, you're a mandated reporter in this country. And so that means you've child abuse, elder abuse, in some settings, spousal abuse, and in some states, this duty to warn tear-off issue is a big deal. California, it's a big deal. We were trained on this. I can't tell you how many hours we got about tear-off, but in my training. But some states don't require homicide reporting for along the tear-off lines. So it really depends on the state. Really need to be aware of the rules in different states. The same thing is true for informed consent. You need to be aware of the informed consent statutes for the discipline you're practicing in whatever state you enter. Some states say you don't need a separate telehealth informed consent. What they mean by that is that you will be using all of the other regular practice informed consent requirements, and you simply have somebody acknowledge could even be verbal, in California it's verbal, that you're using video, for example, that they acknowledge, okay, your treatment will be over video. So it has to be a little checkbox in your EHR or in your paper forms. Informed consent represents a meeting of the minds. This is what that article was about that I referenced earlier, that physicians are being now caught short because they had some document they had the patient sign, but it wasn't a discussion. The document serves as evidence of the discussion, but the discussion needs to happen. And if it doesn't happen, patients can claim that they didn't really understand what was written on that form, they were too rushed, the clinician didn't really discuss things with them, so these are the things that are coming up in litigation. So you really need to have a discussion and have your clinician, or you yourself, if you're the clinician, be able to defend themselves. Now, I have a bunch of slides about this, and I will not read them to you. They are in the slide set. You can get all of my slides, including this set, at slideshare.com, and you can get this, I believe, through NRTRC. So along with this webinar, you can get these slides. But I'm just going to go through all of these: date, diagnosis, all this stuff should be informed consent, or you can at least think about it, put it in there, and I strongly advise you to obtain full legal review with a local telehealth attorney. Don't just go to a business attorney that might be working for your association. Get a telehealth attorney. There are a number of telehealth specific attorneys. Have them review your informed consent to make sure it's thorough. We offer one at the Institute, but it's part of our coursework. And there are very specific things in terms of use the word and in this circumstance, not the word or, and or. So it's legalese. It's important you get this thing straight. So here's some things just as a sort of guideline for you. I want to give you a quick overview of it, but I'm not going to go through it all. Another big deal in terms of best practices is emergencies. This is something that needs to be talked about. Informed consent process, obviously, but discuss it very carefully in a matter of steps. And it's better for you to have your policies, so your informed consent policy written out so that you can lay it out for your client, your patient ahead of time in just one straight shot. And let them know that you need to know who would be their contact, their physician, their family. I always require both. Maybe if it's a school personnel or maybe a religious leader, AA person, AA sponsor, doesn't really matter as long as there's somebody there that you can contact. And on your side, that you know the community resources. What is the time to response for the police department in that community that you're entering? If it's 3 hours because the sheriff goes fishing in the afternoon of the summer, not that good for you. So you may want to you just try it. Try calling 911, see what happens in that community. So it's up to you to get your resources in order, and then know your local collaborators. Who are the best ones? If there's a team that can go out to the home, know that ahead of time. Let your client know when you're going to contact them. So this is part of that policy I just mentioned about you writing it out. And you could say, if I call you twice and I don't hear from you within 24 hours, I'm going to assume something's wrong, and I will ask the police department to go do a safety check. Things like that, so that they get it, that you have a procedure that you follow. So whatever your policy is, just be really clear about it and transmit that. I also want to point you to some guidelines that I told you before. I looked at the American Telemedicine Association guidelines. Here's one that was produced a little bit earlier. It's the video conferencing guidelines. It's the most thorough one I've seen in the United States. And they talk about what I just mentioned to you, doing a patient site assessment, including information about local regulations. If you go to another state and they don't have the same type of 5150, a mandatory hold that you do in your state, you want to know that. And so there's a lot of things here, and once again, I won't read all this for you, but there's a lot of information about just how to operate and keep yourself safe as well as everybody else that you treat. Let's get into some HIPAA high tech. There's 3 parts to HIPAA: transmission, security, privacy. A lot of people focus on security and they fail to they focus on privacy. The omnibus version of all this that came out in January of 2013 said now you have to have a business associate agreement. And the HITECH Act put this in place as well, so that The business associate agreement is something that you need to get from all your vendors, your email vendor if you're using email. Although that same rule, HIPAA said you don't have to have a HIPAA compliant email service if you let your client patient know about the risks of email in your informed consent process, right? But most of us don't do that. Some of us may put an email address on our websites. Client clicks it, writes to us, and now we've gone ahead and had contact with them. We've encouraged them to have contact with us, and we haven't informed them of their. We haven't gotten full informed consent. So it's tricky with those email addresses. Anyway, the business associate agreement is something you should get from any vendor that you're using if you don't want to notify your client ahead of time about all this informed consent related to email. But it's true for video. It's true for your cloud storage. It's true for your text messaging services. And then there are now sanctions imposed if you don't do all of this stuff. Let's talk about Skype because that's always kind of a tricky issue. HIPAA requires an audit trail, which means that there's a trail of all the contacts. And so if anything goes wrong, they can go access it. Much like phone records that get subpoenaed for child custody cases, we need this type of record so that the legal authorities can go access whenever there's a problem that gets to the court. They also, HIPAA says we have to have breach notification tools. Breach notification tools means that when there's a breach, when there's a hacking or breakdown in the connection, you, the clinician, get notified. If you don't get notified, how are you supposed to know? I mean, we're clinicians. We're doing clinical work, so we don't know all that. If you want to know more, Joe McMiniman and I, a physician attorney that I've worked with for years, wrote an article. It's published in the Psychiatric Times in March of 2013 talking about the perils of using Skype. And we link straight out to a lot of government documents, including some from the American Association of Social Work, and there's also one. It wasn't out when this came out, but the American Psychological Association came out with a document in the spring of this year, 2014, and said Skype is not appropriate for healthcare. You may want to be thinking about some of these other options. FaceTime is another issue that says it's right here. To be fair, it's not quite as simple as just opening FaceTime and calling your patient. Specifically, there are configurations that you need to set up in your system, and so does your patient if you want to be using FaceTime, so that is, it's secured with a firewall around it. So you can't just be talking with people or text messaging with people. If you want a list of all these video-based services, you'll see at our website we have over 60 of them listed. Go to telehealth.org/video, and we link straight out to the different companies that have these types of services. I'm going to run through very quickly. Let's see, I have a couple minutes left here. Nursing homes, I'm going to run through 10 different models that have an evidence base, and that's these 3,500 articles and books I told you about. A lot of them basically stack up into these 10 different models of how to practice using telemental health. Connections to the nursing homes, connections to employee assistance programs. There are many insurance companies that are now hiring banks of clinicians to work with referrals that the insurance companies give, and we're going to be seeing more and more of that. But they do have records on the people, right? They have all your insurance application forms when you try to buy healthcare insurance, and also the employer records of employees. And so the clinicians using these services understand who the people are that they're accessing. Rural hospitals, patient goes to the rural hospital, is suspected of maybe having a diagnosis that needs rendering, and so they call in a specialist, a mental health specialist, do an intake, and then they'll properly diagnose the person. Once again, that person is known to the staff that called for that specialist. So over video, a lot of times I'm talking, all of these use video. Schools, the same thing. A child is in a school, child is having problems, the family might be invited to come in and speak with the nursing staff. We're winding up to the end of the hour here. I want to encourage you to type your questions if you have questions now, because I'll try to get to them quickly as we get through. The schools oftentimes have nurses that are present there. So there's, once again, just as the rural hospitals, the nursing homes, the APs, there are other professionals that know other things about the patient, you see, oftentimes medical. There are specialty schools, autism schools, for example, or residential treatment hospitals where little kids are traumatized with all of the procedures they have to go through. So to have a mental health person be their advocate and be talking to them is something that a lot of these groups see as being an advantage. And the thing that we can do if we're interested in serving these groups is not wait for them to come to us. We can go to them. I know a social worker and a psychologist who approached Rural Hospital here in Southern California and got a contract. This is 5 years ago. Now they have 5 hospitals that they're serving for mental health services from their homes in the LA area. One actually lives out in Catalina Island. So they are in their homes and they go and they serve these contracts in these rural hospitals that they've organized, and they do all the psych care for these hospitals. It's a really good thing for you to use the network you have and try to disseminate services out, but you have to go approach them in many of these cases because it's still pretty new. The migration model is one that I talk about. It doesn't have the safeguards of the first 5. You see, the first 5, generally there are other professionals involved. If there's an emergency, you can call those professionals. Or in a nursing home, you make a note in the chart and you then have that medical professional take care of it. But the migration model is attractive if you already have a practice and now you want to move away. You want to move away. You maybe live in New York State and you want to move down south someplace for the winter. Well, you can do that. If you're licensed in New York, you can continue to serve the people in your practice if they're self-pay, if they're cash pay. If they are not and they want to use insurance benefits, you have to negotiate that with the insurance plan. And right now, that's going to be a tough row to hoe. Not many of them are going to want to do it. I think in a few years, a handful of years, we're going to see that change dramatically. But right now, that's one limitation to that model. You also find a lot of companies wanting to serve people online, and they are offering all kinds of models where basically the moment you say that you're licensed, you are attesting to the fact that you know everything about online practice and you're going to take the responsibility for that. What we've done at the Institute is we've set up our own website called providerpanel.com. People can come in, complete a credentialing packet, and then some of these companies partner with us to hire you, but that's after we look at the companies and make sure that they are up to snuff because their legal documents, in many of these cases, restrict you in ways that I find unconscionable. But you can go. I just want you to know there's a model out there. You can sign up for a lot of these companies online. Just be careful and have your legal counsel, hopefully a telehealth attorney, look over those contracts with you. Or if you want to discuss them with me, once again, I'm not an attorney, but I've seen a lot of these, and there are some things to really look out for that I'd be happy to point out to you. Home health is one that's been greatly underestimated. I've been writing about home health and mental health being natural partners for years now. The idea of a nurse going into a home and medicating a patient is one thing, but a lot of times they see that a person is anxious or depressed and they don't have the behavioral skills to impart. That's where we can come in and we can help them. We can serve them. Correctional facilities is another very big group. I know here in Southern California we get notices for psychologists that want to work with the correctional facilities, and they have had telehealth in play for quite a while. So if you want to get a job and work for a correctional facility, you can sit in an office and then they will connect you to inmates that are through various facilities. So you can look for that if you want that kind of job. A lot of times they come with salaries and benefits and those kinds of things too. You'll find a similar arrangement in the military and the Veterans Administration. Actually, the Veterans Administration is one of the largest employers of telehealth professionals, including telemental health professionals in this country. And that largely is because they need a lot of people coming. They need a lot of people to serve our vets that are coming back with injuries that in the previous wars would have left them on the battlefield. But now somebody could be a multiple amputee and survive with modern medicine. They come back and they are quite depressed or anxious, have PTSD, a lot of trauma, brain injuries, and so they need a fair amount of mental health specialty care, and so that's why they're a very big source of employment. And you'll find a lot of the laws that are rolling out for the government get tested through that military VA system. For example, licensure over state lines has been acceptable if you work with vets for years now. So that model it was tested with the VA, and they've found that clinicians are doing quite well with that, and so the vets. The last step of our 7-step model in the online clinical practice management roadmap that we've developed is that of reimbursement. And I wanted to just let you know, those of you that are interested in reimbursement, that Medicare and Medicaid already pay for video teleconferencing. Many third-party carriers do. Of course, they require that you use HIPAA-compliant platforms. So if you're looking at people that use Skype or FaceTime and they're not getting reimbursed, well, first thing to do is make sure your technology is in accord with federal law. You also have to be working from designated sites. So there's one site chosen as for the patient site. They have to meet specific regulations, and so does a practitioner site. Right now, reimbursement is to rural areas only. That will be moving to urban areas. That is right now up for discussion. CMS just released a document, I believe, 2 Fridays ago, talking about delivering rural care through accountable care organizations. And the home is coming down, that was service to the home is coming down the pike. Senator Mike Thompson is one to follow for that. But we just also had 7 new telemental health related CPT codes released for payment now starting January 1st, 2015. So the federal government, CMS, is opening the doors for us to be delivering our care because of, I'm sure, because of a lot of things I mentioned earlier about the need for mental health care. So with that, I'd be happy to take some questions.
Thanks, Marlene. There's one question here I'm seeing in the Q&A pod from Ray, and I don't know. Can you see the questions there?
I don't see questions. I see the pod, but I don't see the questions. But I'm happy to take the question if you want to read it.
Yeah, I'll give it to you, and at the same time explain my ignorance of medical terminology. But he asks if there is any comment regarding the states requiring FF and physical exam with client MDs before allowing a telehealth consult.
Yes, I believe FS is probably face to face, in person, okay, and physical exams. Most states have that. Actually, I believe at last count when I consulted with CTEL, it was 42 of the 50. No, I think it's 32. But that was a couple years ago, so I believe it's gotten even tighter. And that has been a reaction to clinicians being hired by these pill dispensaries, you know, the kind of the pill mills through the internet to dispense medication to people over state lines. And so they kind of put the kibosh on that. It's unfortunate because it does interfere with telehealth practice. And that's where we have to work with senators such as Mike Thompson to say, wait a minute, wait. If we're using a traditional model for telepractice, let's be reasonable here and go along with doing a specialty consult after a primary care or some other responsible entity has done a hands-on intake. It's going to be a hard sell. A lot of the boards don't want to do that. I know there was a physician that was censured in Oklahoma just this last year. In 2012, he sent a nurse out to different homes of the patients to do an intake with him on the video because he himself was physically injured, and the board censured him for doing that, for not doing a proper intake. And they also censured him for using Skype, by the way. They named Skype and said that was an inappropriate technology for healthcare. And I think the other one was not doing a proper informed consent. You see, this informed consent thing is coming back around because a lot of people have been doing improper informed consent. So he was censured on all 3 counts. He had his license revoked for a couple of years. You may want to look. We have a webinar on that at the Institute that you can listen to we have an on-demand library of webinars if you're interested in that kind of thing. But we're not expecting that it's going to be changed anytime soon. So that is a problem.
Yeah, if you have other questions for Marlene, go ahead and type them into the Q&A pod, and I will read them to her because she's not seeing them. And if not, we'd like to thank you all for attending. And we'd like to invite you to take our survey to let us know what you thought of today's webinar, and also to let us know what you'd like to see in the future. And Martha has just shared that survey with you, so please go ahead and fill it out. Marlene, I'm not seeing any further questions coming in. You did a pretty thorough job, I believe, so.
Thank you.
Here's a question from Marlene, or a comment. It says, I'd gone to another telemedicine conference and was told that the new Skype and VoIP are compliant. Any new ideas?
I would be very careful about that. I think some people believe that if you don't type into a system, that the system is secure. The problem with that is if you receive Skype on your phone, or if you even use it on your desktop, there is a place you can go back 30 days later and see all the messages that were typed. If that exists, then there's a footprint somewhere. And remember I told you there's 3 parts to privacy, to HIPAA. There's transactions, there's security. A lot of people are really focused on that, but they're not focused on privacy. If you come to our blog at telehealth.org/blog, B-O-L-G, blog, okay, you'll see, and you type in, there's a little search bar there. If you type in HIPAA or Skype, probably Skype would be even better, you'll see the privacy, no, not Skype, I'm sorry, it is HIPAA, it's EPHI, Electronic Protected Health Information, EPHI, that's what to type in there. You'll see I have a list of the 18 categories of privacy designations that we're responsible to protect. They include, along these electronic lines, they include the name of the person, which a lot of us carry in our Skype interfaces. The email address can be part of it, the ISP footprint, right? Well, if that is blocked by the new Skype, wonderful. If it's not, it's your job to know that it's not and to not use it. So be careful with it. I'd love to see Skype do this. I think I would have seen it because I really do keep track of these things. But if you find an article that explains what you're saying, please send it to me at that address, telehealth.org/contact, because I'm all eyes. I've been waiting for Microsoft, who bought Skype, right, that they own Skype, to get Skype to be up to the standards of HIPAA. I just haven't seen it yet.
Any other questions or comments from Marlene?
Let me just make another comment about that. If you want a free service, there are free services that are HIPAA compliant. If you go to that telehealth.org/video, you'll see there are some in there. And we even list the pricing. If you go to the bottom of the list, you'll see there are a few that are for free. Or you can use them, I think, 4 sessions, 6 sessions a month for free. And so you don't ever have to pay if you just have a few clients and you want to get started on this kind of thing. So with that, then I guess that's it for today, Bob.
Yes, I think so. I want to thank you very much, Marlene, for joining us and for sharing your information and expertise with us. And we will let everybody that's still with us know that the webinar has been recorded. So if you want your associates to see what was happening today, they can come to our website, nrtrc.org. In about a week. It takes a week for Adobe Connect usually to get these things ready for us to put on the server. And all our previous webinars are available up there too. So, come and join us. And Marlene, thank you very much. We really appreciate it.
My great pleasure, Bob.